Good morning, everyone. It's 10 o'clock, and it's time for us to start our weekly coronavirus virtual information session. I want to welcome everyone again for being with us every week and helping us inform you on what we know. If I can just get the next slide, please mute your mics and keep your video off if you do not want to be recorded. I don't mind if you have your video on, if you don't mind with your face on the recording. You can type a question in the chat, or you can raise your hands. Please, then if you would just make sure that you keep that mic's muted all the time when you're not asking a question. Then the next slide, please. If you have sound issues, click on the arrow next to the microphone to test the system. You'll see it right there on the picture. And then the last slide, as always, can we just get the county that you are from in the chat? That helps us just track yet again how we are doing in terms of our reach. Thank you so much. So today I am going to ask Dr. Furman yet again to give us a quick update. And then I am going to ask our Director of Wellness to give a short update as well, Dr. Jody Ambrosio. And then we're going to move over to our discussion of advanced care planning. So Dr. Furman, you're on.
Yes, hello everybody. I'm Dr. Christian Furman. I'm the medical director at the Traeger Institute, and I'm really enjoyed this time every week with everybody. So just want to kind of give an update from what the governor said yesterday. Every day at 5, the governor has an update. And so just to let you know, in Kentucky, there's 87 new cases as of 5 p.m. yesterday. 28 cases were in Jefferson County, which makes a total in the state of 2,048. There are 7 new deaths in Kentucky and 5 in Jefferson County. So that makes the death total 104 throughout the state. So the governor asked for all the flags to be flown at half staff this week because we've gone over 100 patients that have been that have died from the coronavirus, which is very sad. So the one thing about just an update that's going on at U of L is that we're now going to be soon offering decontamination of N95 masks for any organization in Louisville that needs it. So it could be healthcare systems or nursing homes or jails or anybody that's using N95 masks. They can be decontaminated up to 20 times and reuse them. So once up and operating, about 7,000 masks can be decontaminated daily using vaporized hydrogen peroxide. So we can get you all that information, put it on our website of how to actually turn in the mask. They're working out all the details of that. But that's a game changer because there's not enough N95 masks to go around. And as more and more people, become infected with the COVID virus, we're going to need more masks. The other big thing is Laura Morton is on the call. She's one of our faculty, and me and maybe other people on the call have been asked to be part of the governor's task force for long-term care. And so, we met once, it's all by telephone on Friday. We're meeting again today, and really good things have come from that. And one big thing is that the PPE is being coordinated by the state. So if facilities don't have PPE, they just have to get on this website and sign up every day by 10 o'clock and say how much PPE they're using every day. And there's a tiered system. The highest need gets the PPE first, and then second tier, third tier, fourth tier. So we have a coordinated effort in the state to get out the PPE to the facilities and people throughout the state who need it, which is really, really good. Also, a lot of us on the call are members of CAMDA, Kentucky Medical Directors Association. So it's a group of medical directors of post-acute and long-term care. So it's nursing homes, it's assisted living, it's personal care. And the board wrote a letter to the governor and Dr. Stack, the commissioner of public health through the state, and other people to kind of just highlight that long-term care, post-acute and long-term care need a lot of attention. They're doing a good job, but we just want to stay ahead of it. And so, we're asking for the PPE, which was addressed. We're asking for testing, which has been addressed. So now all the facilities can have testing through University of Louisville infectious disease. They can run 100 tests a day through their lab and get 24 to 48 hour turnaround. So we're able to get those tests done. The issue is still getting the swabs, but really, pretty much you can use a flu, what you're doing for flu testing, for the COVID testing. So if anybody around has extra flu swabs, please let us know, because we can use those for COVID testing and coordinate that through U of L infectious disease. We ask for staffing. There's a lot of people that have been furloughed from hospitals because they're not doing elective procedures. And can those staff be then deployed to the long-term care and the assisted living personal care home, so we can the goal is to keep the patients at the facilities, because then the hospitals would be overrun and overwhelmed when the surge comes, if all the patients from the facilities go to the hospital. We want them to go to the hospital if they need to go to the hospital, but we're trying to address that by keeping everybody at the facility. The other thing that we had in this letter from CAMDA was we need the facilities to have more medications to be able to treat patients at the facilities. All these facilities, there's no pharmacy on site. And so you have an emergency kit where you're able to get the medications, emergency medicines on site. So we're asking for the Board of Pharmacy to change their regulations so we can have more opioids and medicines to treat people for shortness of breath at the site, make sure there's enough oxygen at each of the sites. So we're addressing all those systematically. And Laura, was there other things that the CAMDA board asked us to address through the long-term care task force?
I think the other thing that we're considering is just about looking at the regulations and some liability in these times, because as you all know, the nursing homes are highly, in post-acute settings, highly regulated. So I think the KMDA is asking for the state's help and looking at some protection for facilities and providers during this pandemic time.
And other states have done that, so we're modeling off other states. So yeah, that's a good point. And then, but if you all have other suggestions of things that we should take to the long-term care task force, please let us know, because we are meeting today at 2 and we'll be meeting on a regular basis, and we're happy to share people's concerns with the task force. It's a group of doctors, administrators, bioethicists, a range of people that work in long-term care. So that's the update with that. Just in general, if you look at the numbers, 30% of the deaths, there's over 100 deaths, 30% of those were in long-term care and post-acute and long-term care. So we really want to make sure we're addressing that population. And I just want to remind everybody that we are doing telehealth in the office. The office is open every day in the morning physically. We're not, U of L Health has a new policy where all the waiting rooms are closed. So our patients that are coming in for those appointments are coming in, they're getting their mask, we're getting their phone number, and we're asking them to go back to their car to wait. And then when we're ready to be seen and get their vital signs and take them back, we're calling the patient and bring them back in. Also, people are coming for labs. And U of L did close its lab at the Healthcare Outpatient Center, ULP Outpatient Center, U of L Health Outpatient Center, but the U of L Hospital lab is still open. So our lab is one of the few labs that is still open. So we are, able to take people's labs and drop off urines. But what we're doing is when people come in for that, we're getting their name, their phone number, asking them to wait in the car, and then our lab person is calling them back when she's ready to draw the blood. So I'm sorry we had to close our waiting rooms, but this was a U of L Health decision to really protect both ways, protect the patients and protect the staff. So that's one big change, but really we've gone to mostly telehealth. And so if people have any problems, we're getting them pretty much a telehealth appointment the same day or the next day. We have providers all day long doing telehealth appointments. So please continue to call our office if you need anything. We can get you seen by telehealth. And then if you don't have the video capability, we can just do a phone call, which it works pretty well. And if the provider really thinks that you need to be seen in person, then the provider will ask, for you to come in to be seen, and we have somebody staffing the clinic every day. So I think those are updates from that. And then maybe I just want to, Dr. Joe is going to talk about wellness, but I just want to emphasize that we do want people to stay well. And the big way is to improving your immune system. We know that the COVID virus, it's your own immune system that's, fighting this virus. And Dr. Joe has great ideas about how to improve your immune system to fight this virus.
So just before I let Dr. Joe speak, let me just also say that in light of keeping us all healthy, we are still doing our annual wellness visits. We are still doing, we're going to talk about advanced care planning. We are still doing all of those in our clinic. So you can just call if you need any support to get your preventative care also taken care of. And on that note, Dr. Joe, anything you want to add?
Okay, thank you, Dr. Anna. I think the one thing we've learned from this pandemic is that if your immune system is low, you put yourself at risk for getting this virus and other viruses. So I think we've learned that we really have to start to build our immune systems up, and there are ways to do that. One of the simplest ways is to begin to eat healthy. Get healthy with good nutrition. And what we try and do is really lower the inflammation within the body, and shifting over to a more plant-based diet has been shown by thousands and thousands of research articles to improve the immune system. Secondly is exercise. So I know that we're all stuck at home and it's difficult to exercise. I normally go to a gym, but what I've been doing is something very simple. I have this gallon of water that makes a great weight training system for me each day. So do something, try and get in at least 150 minutes a week. That's 2.5 hours a week of doing something. Getting that heart rate up is real important too. So if you go for a walk, a nice relaxing walk is good, but also try and pick up the pace a little bit if you can do it. The third thing I want to talk about is sleep. I know that a lot of people, a lot of my clients have sleep problems, and it's real important to establish a routine when you go to bed. I know this is hard for some of you, but take those electronics out of the room, maybe your TV out of the room, and start when you go to sleep, spend a good half hour getting ready to sleep, relaxing, taking the time to get yourself a little warmer, and then being able to get a good night's sleep, 7 to 8 hours of sleep. And then lastly, your mental health. Stress is killing us. It lowers our immune system. It hurts our immune system. It lowers our ability to respond to sicknesses. So how do we reduce stress? How I reduce stress is, and this is really, I've been enjoying it, staying home, because I've had a chance to meditate 3 or 4 times a day. Even if I take 5 minutes, I'm able to just work on reducing my stress. So I think if we can get away from the chips now that you're home and those snacks and start eating healthy, sleep better, do some exercise, and really control that stress that you're having during the day, I think that we can build up our immune systems that will be able to fight this virus and other viruses that are going to come. It's been happening since 1918 with the Spanish flu. These viruses are morphing. They're getting stronger. Probably will happen again. So let's give it our best shot at building up our own systems so we can fight them. Thank you.
Thank you. Now that we have given us our updates, I'm now going to introduce you to 4 speakers, all from the Traeger Institute, who is going to talk about advanced care planning and goals of care during a pandemic. The first person is Dr. Furman. You already met her, and she gives us an update every week. She is our medical director, and with her is going to be Dr. Morton. We will also introduce her quickly today. She is the director of the Division of Geriatric Medicine at the Department of Family and Geriatric Medicine. And then we have Angela Leinenbach. She is an assistant professor at the School of Nursing, and she's also working as a APRN in our clinic. And we have Justin Magnuson. He is our Project ECHO coordinator, and he's part of the Kentucky Most Coalition. So those are the 4 people. Welcome, and please share your knowledge of us. And then we can open up for questions.
Good morning, everyone. So today we're going to talk about the importance of advanced care planning. We'll provide an overview. We'll identify the techniques for a goal of care conversation. We'll discuss and review the medical orders for scope of treatment form, and we'll talk about advanced care planning during COVID-19. So why this is important. So if you look at this picture, there's a picture on the screen of myself and my grandmother when I am 8 years old. My grandmother at this time is 63. At this point, my small family, it was at this point, my uncle, my grandfather, myself, and my grandmother were our family unit. And you wouldn't really think about discussing end-of-life issues or end-of-life planning at this point when I'm 8 years old, of course. But 17 years later, the only surviving members of my family were myself and my grandmother. So my grandmother is 80, I am 25, and my grandmother is still living in rural Indiana. My grandmother is lucid on a Friday afternoon. We have lunch. Sometime that day, she drove herself to the hospital, and by Sunday, she was delirious and did not know why she was there. That began my journey of navigating her healthcare over the last 5 weeks of her life. And the only thing I knew going into this is that I was her healthcare surrogate and that she was do not resuscitate. And that was not really enough information to help make informed decisions over the last 5 weeks of her life. So when you think about this, advanced care planning really helps support the triple aim. It really helps support the health and well-being of patients by providing them the care that they would like to receive. It really helps improve system outcomes by really streamlining services and really providing the care that aligns with the patient's values. And it is cost effective because you are making decisions that really do align with the patient values. And most studies show that people at the end of their lives will choose more conservative care in terms of not getting life-prolonging treatments or treatment that they're not going to go for an extra round of chemotherapy if they can avoid it. They're not going to typically get heroic measures. They really are looking at comfort and looking at quality of life. So if you look at 50% of older Americans go to the emergency department in the last month of life, 75% are hospitalized, 66% of these people die in the hospital. 40% of the Medicare patients receive intensive care in the last month of their life. Lots of people go to the hospital at the end of their life. 80% of people worldwide would like to die at home, but over 50% of people, or around 50% of people, die in hospitals. So you can see that making decisions at the end of life and having conversations can really help set people up. And when we get to the end, we talk about goals of care conversations, can really help people align their values and the care that they get during this often stressful time. So dying well is living well. Dr. Furman always kind of refers to this when she does this presentation to talk about, whom do you want around you? What conversations do you want to be having? What care do you want to be having versus being hooked up to ventilators or having a highly medicalized death? Really taking all this into consideration is part of the advanced care planning process. So when we think about advanced care planning, this isn't just for people over 50. This is really ideally for everyone. So in my fantasy world, at 18 years old, everyone is starting to have advanced care planning conversations and making decisions around who would be making these decisions for them if they couldn't make them for themselves. Dr. Furman actually talks about giving her daughter a living will for her 18th birthday as a way to start the conversation early. Prior to diagnosis, this is not a conversation that you want to be having whenever. This is not a harbinger of bad news. This is a conversation you want to be having before you're diagnosed so you can be making informed decisions over the course of your the disease process. This isn't, again, just limited to people, adults or older adults. This is everyone. Children born with debilitating or life-limiting illnesses can be involved in this conversation. Anyone that's going to be having surgery and anyone with a chronic disease or acute life-threatening events. So really, ideally, this is happening way before a chronic disease, but if you have some kind of catastrophic diagnosis, having these conversations can really help make informed decisions and help support you, your loved ones, and your healthcare providers. When you think about this over the course of a long disease trajectory, when you get the initial diagnosis, particularly we're thinking about heart disease, diabetes, Alzheimer's or related dementias, cancer, illnesses that have a long trajectory. This isn't something that happens, ideally at the very beginning. So as you're going through the goals of care conversations, this is over a long trajectory, and it's not just at the end. So at the end of this illness, you're getting into hospice care and into palliative care, but really this could be a continuum of care that incorporates this over benchmarks over the course of this trajectory. And then here at the end, when you get into hospice care, this is really providing psychosocial care. This is really providing really comprehensive care that supports you and your family. And then after the death of a patient, when they're in hospice care, that also includes bereavement services for someone up to 13 months. So this is not just, and palliative care and hospice care are not synonymous. Palliative care is really comprehensive care that's can be delivered concurrently with traditional treatments. And then as you transition over the course of this into hospice care, that can be up to 6 months. And that 6 months can then be renewed if it's deemed still necessary. So this isn't for somebody that's at the very, very end of their life. This is a long tail that's incorporated into this treatment. So the goals of care conversation, I'm going to bring Angela Leinenbach into this conversation to really go over this and really help you understand how this fits together to really help patients and their families make informed decisions. So Angela.
Good morning, everyone. And Justin, thank you so much for sharing your story and also your passion for having these discussions. So today I'll go over a few techniques for discussing goals of care. We'll go over the MOST form and advanced care planning during this time of COVID. So when we think about techniques, we want to think about what goals do we need to establish, who needs to participate in the care, what are the details of the goals of care discussion, and then also the details of a DNR, or do not resuscitate, or allow natural death. So let's go back that one slide, sorry. So when do treatment goals need to be established? I think Justin talked about this a little bit, but they can be established in the hospital. They can be established when a patient has an exacerbation of a chronic illness or even an acute illness. So chronic heart failure, COPD, or now we're even talking about this, during the COVID virus. It also needs to be established when a person is being admitted to a nursing home or they're changing their level of care, for example, an assisted living or personal care environment. And then, of course, during like Dr. Furman's daughter at 18, these healthy outpatients as part of a routine discussion on advanced directives. So who needs to be part of this discussion? Obviously the patient, especially when the patient is decisional. However, if the patient is non-decisional, then that information would follow the advanced directive. And then the durable power of attorney, the healthcare surrogate, if those things are not in order, then it goes to next of kin. So that would be a spouse, then an adult children, parents, and other relatives. There are some states out there that then will list friends, and there are also some facilities that will allow physicians to make that decision. We want your provider to be involved in these discussions, and other people that are very valuable to this team are your family, your friends, social workers, nursing, and chaplaincy. So in discussing these goals, you really want to decide in your own mind what, if any, treatments are inappropriate. One of the things that we're kind of looking at now is, maybe you were going into the office and getting B12 shots. Is that really appropriate in this environment? Is that appropriate if you have a decline? So talk with your provider about those things. It is important to not be rushed when you make this decision. You want to find a very quiet, private place to meet. And then we really want to get a handle on what do you know about your health? How do you feel you're doing? And then we review with the patient or next of kin the current condition, the expected prognosis, and then we want to invite questions during this treatment discussion. So when we talk about broad treatment goals, the first one that we put them into 4 categories. The first one is cure. We want to do everything that we possibly can to eliminate disease, to promote wellness. That's one treatment category. The next category would be rehabilitation. Are our goals to restore care, maintain care, or to minimize any further loss of function? That third area, I like to think of this one as life-prolonging palliative care. Let's think about that patient that her daughter may be having a wedding and she's looking forward to that wedding and she wants to do everything that she can to get to that wedding, or the patient that doesn't have their affairs in order and they really want to just do everything that they can in order to have that extra time to get those affairs in order. And then the fourth treatment goal is really focused on comfort-focused palliative care. There's nothing that we're going to do to prolong life. There's nothing that we'll do to shorten it, but we're gonna let nature take its course and keep you comfortable during that time period. So we discussed reasonable goals of treatment. We definitely encourage and invite questions. We develop a plan kind of based on those levels of care. You decide if issues of minimizing current treatment or you want to implement comfort-focused care, and then you document that in the medical record. So there are, to talk a little bit more in detail about the types of advanced planning tools, we've kind of put this into 2 categories. A more traditional tool of doing this is the healthcare proxy, the living will, or healthcare power of attorney, or healthcare surrogate. Those are more traditional methods. Those are methods that you use kind of more for future care. It's not typically done in an immediate situation. The second form, I think you've heard us refer to the MOST form. It's an actionable medical order. So it's direct and immediate impact on a course of action. Here in Kentucky, we use the MOST form, and that form goes over do not resuscitate or allow natural death. It has 5 different categories that are very specific about your goals and wishes during this time, and we'll go over that. So the purpose of the MOST form, it provides a mechanism to communicate patient preferences for end-of-life treatment, and it's across treatment settings, whether it's at home, in a facility, a hospital, or in between. So for those of you on the computer, this is a copy of the MOST form. It's a pink piece of paper. They have it be pink because it has to be the original document. You can actually go to the MOST Coalition, and we'll give you guys resources at the end that you can look up the document, and it gives you some documentation for how to the different sections and kind of how to fill that out. So differences between, there are some major differences between the MOST form and advanced care directives. So typically we use the MOST form for our more frail, serious illness patients that may have less than a year to live. The timeframes are different. The advanced care directive is more, like Dr. Furman's daughter who's 18, you can do an advanced care directive then, but the MOST form is more for a more immediate situation. So who completes the forms? Individuals complete the advanced directive. The MOST form is completed by your healthcare professional, and it's signed by a medical doctor. The settings are a little bit different. Typically, the MOST forms are done either in the medical office or in the hospital or in a nursing home, where advanced directives are typically completed in your home. So in the roles, so typically a surrogate, the patient, him or herself, has to do the advanced care directive, and that has to be done before if a patient is non-decisional, then that surrogate or that healthcare surrogate could then aid with the MOST form there. The interesting thing about the MOST document is it is portable. So we have patients that live in their home, they put it on the refrigerator. That document will go with them in the ambulance, and if they were to go to the hospital, and then it would follow them to the emergency department. That way, all of the people involved in the care would know exactly what your wishes are and what you want. And then the MOST documents have to be updated annually. So the MD would have to review them and sign off them once a year. So where the advanced directives are really kind of your responsibility to make sure that your provider and or the hospital has those documents. There you go. So the benefits of the MOST form, you have very clearly established level of goals that are explained. It ensures that the patient's wishes are honored. It really gives staff, and especially staff that you may not know well, if you were to go to a hospital, comfort that with those difficult conversations, they know exactly what you want. It decreases hospital readmissions, and it decreases length of stay. There's some information about the MOST form in Kentucky. It is used throughout nursing homes and healthcare systems in the state. The State MOST Coalition was formed in January of 2017. And there are over 100 members, different facilities. You've got U of L, UK, the VAs, Hospice Health, Owensboro, Baptist Health, Morton, and the Kentucky Association of Hospice and Palliative Care. It's being used in over 15 counties. And our goal is really to have this form used in every single county in Kentucky. You can go ahead and skip to the next one. So who provides the service? You have physicians that are providing the service and other qualified healthcare professionals, such as nurse practitioners, PAs, and licensed clinical social workers. I think Dr. Furman did mention that we are doing these in our office. We can do this through telehealth, through video, and we're doing this kind of with all the members of our team. There was an interesting study that comes out of Oregon and their version of the MOST form. And one of the things that it showed was that once they started using this form, more people were able to die at home of their own choice. They reduced ICU admissions. They had more increased days at home. And they showed basically they had lower rates of feeding tube use, and that feeding tubes really did not extend the life of dementia patients. So it is showing that using these forms does really make your voice heard. So key takeaway points, the form is not really the main thing. The main thing is to share these conversations, make sure that your friends, family, loved ones know exactly what you want. And a MOST form does not replace the legal document of an advanced directive. Okay, so now we're going to switch gears and really talk about the how advanced care planning relates to COVID. What we're finding out is that, and we've seen in the news, most people who get COVID have very mild, moderate illness. They don't need to go to the hospital. They can be managed via telehealth. Unfortunately, older adults and those with pre-existing conditions, the diabetes, heart disease, COPD, are those that are more severely affected. There's so much fear and uncertainty out there. So it is very important to talk about these choices and planning during this time. And again, you can do this with your providers. You can also do this with attorneys, where there's been some interesting laws with all of this that have taken place that you can actually meet with your attorneys over telehealth as well. So there are some attorneys that are doing that. And then really think about, if you do become ill, what do you want? Do you want to be managed in your home? Do you want to go to the hospital? And then here are some of the resources from the MOST Coalition, from the Conversation Project, and Respecting Choices. And I think, Dr. Furman, did you want to do kind of a mock?
Yeah, thank you. Yeah, Justin and Angela, thank you all so much. It was a really good background. And I just want to kind of frame this, that, you know, the reason we're having this discussion is that we need to have, you know, this is a great forum. We're doing this once a week. We have a captive audience. We've been, Justin and I and everybody, Angela, Laura, everybody's been preaching advanced care planning. So we thought we'd take this opportunity to get everybody to do their advanced care planning. You're at home all day. You can talk to your family. You can get all your affairs in order. Like now's a good time. And so we want everybody to plan ahead and have an advanced directive and have a plan. Not everybody needs the MOST form, but during this COVID pandemic, you know, we really, the nursing homes, the long-term care, assisted living, personal care is a big focus now. The state is starting to really realize we need to have a plan for all these facilities. And the best thing you can do if you are the medical director of one of these facilities, if you work in one of these facilities, if you have parents, if you have family in one of these facilities, is to make sure everybody has their advanced directives known and figured out and honored. And so we're going to do a role play to tell you how to have this conversation. I don't want to scare anybody. You know, Dr. Yankee Love, our director of research, we don't want everybody to think, you know, we're picking on older people or anything. It's just that older people have a lot more serious illness, but you can have a 50-year-old with chronic serious illness that this COVID is very much going to affect them, you know. So anybody that you know that has diabetes, heart disease, COPD, everybody needs to be having these conversations, because if we want to make sure patients' wishes are honored. And the only way to know what their wishes are to ask them their wishes. So that's what we're trying to do, is figure out what everybody wants. So it's not a big surprise. It's a crisis enough. We don't need to make it a double, triple crisis by not having a plan. So we're trying to plan ahead. And so this case is this patient that I'm going to be the doctor and Angela's going to be the patient. Oh no, you're going to be the family member of this patient. It's a family member. It's a daughter of this patient. And this patient does have dementia and does live at a nursing home. And so Dr. Morton, Laura Morton, sent us this role play. I think you got this from where did you get this, Laura? The American Medical Directors Association?
Yes, I did.
Yeah.
It's the National Nursing Home Organization for Medical Directors, and Society for Post-Acute and Long-Term Care Medicine. So they have a lot of really great resources.
And Dr. Morton's on their national board and nationally involved in that. So thank you for sending this. Great. So we don't have to recreate the wheel. Other states are doing this. We need to just, you know, just do what they're doing. So so I'm gonna be the doctor, and I'm gonna have this conversation with the daughter of a patient with dementia who's at the nursing home. And we're doing this systematically in our nursing homes, calling families, and to make sure we have all the advanced directives very clearly documented. And we need to do this in nursing homes, assisted living, personal care, even independent living. So hello, is this Ms. Leinenbach? I'm Dr. Furman from the COVID response team.
Hi,
Hello.
this is Angela.
Very good. So I understand your father has tested positive for COVID.
Yes, he has. I'm really worried. I just have so much guilt. I really didn't want him to go to a nursing home to begin with, but I thought it would be okay.
Well, anyone would be worried in this situation, and there's no way that you could have known that this COVID pandemic would happen.
I suppose so.
Is it okay if we talk about what COVID means to your father?
Yes.
Okay, may I first ask, if you're the person who makes medical decisions for him, are you the healthcare surrogate?
I am. I have the papers.
Yes, perfect, perfect. So I'd like to make sure I'm always talking to the right person.
That's me.
Okay, good. So, and I'm sorry to be doing this via telehealth, but you know, everything now is telehealth, so we're not doing anything in person. So that's why we're doing this and getting everything organized. So I need to give you some background. Most people who get COVID have a mild or moderate illness and they do not need to go to the hospital. Most people recover. The people who most often get a severe pneumonia with COVID are older people and have existing medical problems like your father.
I know that's really what I've been hearing on the news, but it's really scary to think about it.
Yeah, it's a normal reaction. No one really wants to think about this, and COVID has put us all in a very, very tough situation.
Yeah, I know it has, and I know you're busy.
Well, I appreciate that. Yeah, I mean, we're doing the best we can under these circumstances. So I hope your father has a mild case and he can stay here at the nursing home. We can make sure he gets all the treatment he needs here. We have oxygen and we have the treatment here. However, as COVID becomes severe, and I'm sorry to say this, it most likely will take his life given his overall condition.
I was afraid you were going to say that.
And it's not really what I want to say, and it's not really what families want to hear. But given that if the worst case scenario happened and he was going to die, do you think he would rather be in the hospital or at home? Or, I mean, he's at the nursing home. Would he rather be at his nursing home?
That's a big decision. I don't know.
Yeah. And I can see that you want the best for him. And
yes.
Yeah, that's okay. So let me put it another way. And if he did not have dementia and he was, able to make his own decision as sharp as you and me and understood everything that was going on right now, he understood that COVID, what it was, and that what would happen if he got a severe case of the disease. If he were sitting here with us today, what would he say?
Oh, he would definitely say, I'm done, enough, I'll stay here. I don't want to go anywhere.
Well, it sounds to me like if you put on his hat and were him and become him, he'd say enough already. But if you have your hat on and you as his daughter, you say, I don't know. Is it? Do I have that right?
I think you do. I'm not ready to let him go.
Yeah. Well, tell me more.
Well, I mean, he's always been there for me. He's been there for our kids. He's really always believed in me, and he's really kind of that backbone of our family.
So would he believe in you now, and would he want you to speak for him?
Well, I mean, when you put it like that, I know the answer, but it's not what you want to hear or what you want to say.
It's not the kind of decision anyone wants to make. It does sound like the two of you may have talked about this in the past.
We have. When he was first diagnosed with dementia, he was just a little forgetful. It really wasn't a big deal. We were driving to the park one day and walking the dog, and he turned to me and he said, when I can't walk the dog or do the things that I want to do anymore, it's time to let me go.
Wow, thanks for telling me that, because we always want to know, what he would have said if he was in this position. And I really appreciate you telling me that story.
Yeah, I think, in all this fear and crisis, you forget about those conversations. But yeah, I can see him, telling me that that's what he would want.
Well, that kind of memory is a gift. I mean, it really is not you making the decision. It's him making the decision and you honoring what he said. And would be okay to honor that decision now?
Yeah, I think so. I think we need to keep him here in the nursing home.
At his home. Well, thank you so much. So that's what we're going to do. I'm going to write the orders, and we're going to take care of him no matter what. And we'll just take care of him here. So that's the end of timeout. That's the end of our role play. And so I think the whole point is that, these are COVID times and it's not the same as normal times. And we have a different standard of care and we have a different thought process. So sometimes we can't have this big, long goals of care discussion. We have the COVID discussion, and the COVID discussion is right now, he might get COVID. He might get a bad pneumonia where he can't, breathe. And does he want to be sent out? Does he want to be kept here? And so, we're going to try to keep them here at the facilities. And that's what our long-term care task force is trying to do. I don't know, Laura, do you want to talk about anything, or should we not talk about anything else? Or what do you think?
No, I think it's important just to talk about the COVID conversation, and that it could change after COVID. I think it's important for people to remember that, so that if you make a decision or a goal now, you might change it in 3 months once we're over this pandemic. So I think and that's what I found in my experience working with my residents who live in the personal care and long-term care setting. And some people say, well, right now I wouldn't want to go to the hospital because I don't want to risk being exposed to things, and so I'd rather stay here. But that conversation may be different again in 3 months. So I think it's important to remember that that this can be a fluid discussion.
And that's a good point. I think, and I think people have seen on the news, and it is true. I mean, U of L Health and most hospitals have changed their visitation policy, and the family is not there. Well, even at the nursing home and the long-term care, the families aren't there. So it's just really, really hard. And at least at the long-term care facilities, the staff is there that the patients know and the residents know. And going to the hospital, especially with someone with dementia, is very they call it transfer trauma, and
Yes.
it's traumatic to go in the ambulance, and it's traumatic to go to the hospital, go to the emergency room. And it's fine if that's what they want, and if someone wants that, and it's, if they don't have many medical problems and they don't have dementia, or they have just a very mild form of dementia. So it's really an individualized discussion depending on what the patient's diagnosis are. It's not just one size fits all. And I think
Do you have
also
any questions for the group?
Yeah, we can take questions. And also I think just to remember, the nursing home is the patient's home, and that's what they know. And so it's just, most people, if you ask people, they'd rather stay at home, and most people would rather die at home. And so that's what we're trying to do with the long-term task force, is to make sure that can happen. I mean, we're also doing a lot of other things with the PPE and the swabs and everything else. We want people diagnosed and treated early and quickly and sent to the hospital right away if that's what we should be doing. It's just that we want to make it individualized for every patient at the facilities. And one thing, Justin, that you said, and I think that's true, I just want to emphasize that palliative care and curative care can coexist. So you can, be getting your chemo and be getting your dialysis and be getting this life prolonging care, and even trying to cure people, be on the transplant list to try to get a new heart. But in the meantime, you can be doing palliative care principles. So definitely it's not like a black or white. You can have a middle ground there.
Can I ask a question from the chat?
Yeah.
So Joy says she's getting feedback from families who have loved ones in facilities, and their loved ones are exhibiting increased anxiety and dementia behaviors. And they're feeling desperate. They need to take their loved ones out of the facilities and try to manage at home. Do you have any thoughts?
Yeah, Laura, you had a call like this last night on our call. Yeah, someone called our office.
I think it's a great question, and we're all struggling with it in our setting, because it is difficult. People with dementia don't do well when they don't have that regular stimulation, and schedule and routine is so important in people with dementia. And so in this time where we're keeping people more isolated and quarantined in their rooms to minimize the risk of infection in these facilities, in these communal living settings, it is very challenging. I think a lot of facilities are doing well at trying to be creative in activities, trying to do one-on-one activities, trying to do, and I'm sure you've seen some of these things on Facebook, call bingo, where they'll bring them to the doorway of their room so they're socially distanced, to have that in place. If people feel more comfortable with having their loved one at home and have the capability, I think that's great if people want to do that. It's a very individualized discussion, but a lot of times the reason someone's in a facility is because they require around-the-clock nursing care, or just require a lot of intense staff time and care with the basic things like bathing, dressing, feeding, turning, and mobility. And a lot of people can't do that at home. And I think it's important for us to support that, because, I hate for families to feel guilty if they can't do that, because it's so much work. And
they're not a nurse. I mean, it takes a trained nurse. I mean, I don't know how to turn people. There's a technique to turning people to changing their adult briefs, and not everybody knows how to do it. Yeah.
And I think the other thing I would say is just reach out to the activities directors, because a lot of facilities are doing so much stuff over platforms like Zoom or Skype or FaceTime, and trying to allow, if you bring in an iPad to your loved one's room, where you can have that conversation. So I think we're getting more creative in ways that we hadn't in those settings before, to try to allow that connectivity with families. Some facilities, if they're a one-floor facility, are actually doing window visits, not opening the window because that would be exposure, but doing window visits where you can see the loved one outside the window, and you can maybe be on the phone and talking to each other. So I think I would say always, it's a very individual discussion, but reach out to the activities directors, social workers there, because that interdisciplinary team approach really helps connect the families with their loved ones.
Mm-hmm. And I will tell you that the nurses, I mean, most of these facilities are pretty stressed and stretched. And so, you know, they're trying to call the families every day for an update, and the families are trying to call in every day for an update. But some families are calling like every hour for an update, and it's too much for the nurses to keep up with an every hour. They're trying to take care of the patients, you know, so balance, you know, just, and everybody needs, and I've heard this said at, you know, our long-term care calls, this is a stressful time. And so please show compassion to the nurses, show compassion to staff, show compassion to each other, because, you know, it's not going to be the exact same care and the quality of care that they've been getting in the past, because everybody just has a lot more added to their plate. So other questions or thoughts about how to have these conversations, or who to have these conversations with, or the documents? You know, you can go on the website to get a living will, and yeah, go ahead, Justin.
So I'm going to share in the chat a link to the Kentucky Living Will form, to the Conversation Project, and I'll just give a brief overview of the Conversation Project. What it does well is it breaks down this as a series of pieces to help inform the completion of an advance directive. So it helps really reflect on your values. It helps identify who in your life would honor those values if you couldn't speak for yourself, and then gives you some prompts to engage in that documentation piece. So I'll have a link to that, a link to the Kentucky Living Will form, a link to the MOST form, and then a link to, there's a National Healthcare Decisions Advanced Care Planning workshop tomorrow from 11:30 to 12:30. And we're going to provide free continuing education for nurses, social workers, and chaplains. And so I will share that in the chat. But like Dr. Furman was saying, the MOST Coalition also has all of these resources on their websites. And I will be updating the website to include some specific COVID resources. So Dr. Morton, if you could share with me some of the resources you have for long-term care facilities, and I'll make sure that we're compiling all this on the MOST Coalition website as well.
I'll be happy to, Justin. Thank you.
And also just to let everybody know that, you know, the Traeger Institute, or Optimal Aging Clinic, is available, and Laura and I are available throughout the state, you know, to help. That's part of our long-term care task force, is to help the whole state. So if you know people throughout the state that their medical directors or their nurse practitioners or different people at the nursing homes might just need help having these conversations and teaching people how to have the conversations, just let us know. Yeah, so thank you for putting the slide up there, but our number is 588-4340. And you have to, well, press 1 or 2, because this is, you know, clinic and Traeger both. So either way, you will get a hold of somebody, and you can tell them that you know, want us to help have the conversation. You can schedule an appointment. We can do a telehealth visit and have this conversation with a family member, or, you know, now we can do these calls, 3-way merge calls and stuff, so we can have the right people on the phone to have these conversations. So we'd rather have the conversations now before the surge hits. I think they're still saying the surge might be May 4th or 5th. I haven't got an update on that, but we want to be prepared. So we're trying to have these conversations now. And it's really, you know, like the MOST form can be filled out like 100 different ways. So it's whatever, there's no right answer. It's whatever the patient would want if he or she could speak for himself.
Any more questions for the group? I just want to remind you all to type in your county in the chat, if you don't mind. It helps us to just keep track of our reach. Some of you have, but there's still a few missing. So any more questions? I just want to reiterate what someone said in response to what Dr. Joe said. Carrie Hatfield indicated that Fitbit Premium is free to all for the next 90 days, which includes hundreds of workout videos, guided programs, mindfulness meditation for stress, sleep, and meals. So great resource. Thank you for sharing that, Carrie. And then I wonder if there's anything else that anyone...
And I did see some emails, things in the chat about the PPE. And so the website is tinyurl.com/KYPPE request. So we put it in the chat, but that is how you can request the PPE. It's tinyurl.com/KYPPE KYPPEREQUEST.
All right.
And if you need swabs, if you know of anybody that needs swabs or needs testing for the COVID, just you can call that number 588-4340 and we can get you the details on that.
Okay, if there's no other questions, we will see each other again in a week. Thank you so much for our team for presenting, and thank you for all your questions. And please reach out to us if you need any support or guidance during this difficult time. Thank you, everyone.
All right, take care. Wash your hands.
Be safe.